Hello everybody, I'm Dr. Deeksha Pandey and you are watching Urogynecology for Beginners. As many of you have requested to show a case of hysterectomy for the patient who has undergone previous cesarean. So this is a good news for you. This patient has not only undergone one cesarean but she has got it done twice before. This video is going to be a slow one as it is a teaching learning video and a proud moment for me because my first year has done her first hysterectomy here. The patient presented to us with abnormal uterine bleeding, dysmenorrhea and also some bladder symptoms. During the course of the surgery, you will understand why she was having bladder symptoms like frequency and urgency. Disclaimer is that the video is going to be very slow, demonstrating each and every step very slowly in a step-by-step fashion. So, if you're interested, watch it. The surgery starts with giving a skin incision. For skin, while we use a scalpel blade, for subcutaneous fat, we usually use a monopolar cautery pen. When you cut with cautery, a trick is that you have to be very slow as compared to when you cut any tissue with a knife or a blade. The reason is that cautery is simultaneously doing two functions. First, it coagulates and then it cuts. So you have to be slower in your pace as compared to when cutting with a sharp knife. Now, in cases of previous surgeries, especially similar to this one who has already undergone two cesareans before with the same incision, you expect more tough tissues, little more bleeding, and also adhesions between the layers as compared to a person where this surgery is the first one. This yellow thing which we are seeing here, is all fat, the parietal fat. And the white thing which has started appearing now is the rectus sheath, the anterior rectus sheath. These sutures are from previous cesareans. Usually in second cesarean, we use non-absorbable sutures. So this is the same non-absorbable suture. If you find these sutures, you need to remove them as they are not doing any specific purpose here now. They just lane the tissues as foreign bodies. The rectus sheath can be cut either with a monopolar cautery or with scissors, whatever you are comfortable with. Always remember to utilize the entire incision when you are going beneath the skin. To create more space, rectus muscle is detached with the overlaying rectus sheath in upward direction. The same technique usually we do not do in a downward direction because it has been seen that if you go near the pubic symphysis and the periosteum attached to it, it leads to more postoperative pain. As it is a case of previous cesareans and more adhesions, a sharp dissection is required. The technique we use here, carefully look at it, it is called cut and slip. Cut and slip. For peritoneum, lift it up with the help of artery forceps and nick it with a blade. Once you are sure that nothing is adherent below it, extend it either with the help of fingers or with scissors. Here is the uterus. As you can see in this case, it is actually densely adherent to the anterior abdominal wall. Can you see it? The adhesions are up to the cornua on one side. I feel holding the uterus at its fundus with the help of a bulldog is a very nice, extremely good way to give traction. In this case, first work on the adhesions a little bit to normalize the anatomy. The technique of this adhesiolysis is first create the space and then only you must cut. Don't cut blindly because you must understand that the bladder might be there below these adhesions. Adhesiolysis should be done a bit at a time. Create space and then cut. Create space, then cut. And go on bit by bit like this. Use traction and counter traction. Traction is given by the bulldog on the fundus and counter traction is with Babcock's or a non-tooth forceps on the adherent tissues. Some previous two cesareans are so easy and smooth. However, some will have dense adhesions like this. So every case needs to be individualized. And remember, whenever you are releasing adhesions from the anterior surface, which are usually seen in cases of previous cesareans, you have to be extremely careful. You should try not to cut the bladder. In case if you feel that the bleeding is more, that is soiling the field and hampering the visibility, you may inject some diluted vasopressin solution onto the uterus. It will help to minimize the blood loss. Remember, cut only small bit a time. Why? Because even if accidentally you cut on the bladder, the neck is small and the injury is less. Now, can you see this yellow fat here? Whenever this yellow fat comes, you must realize that the viscus is nearby. All pelvic viscera are wrapped with a visceral fat layer. So whenever you feel that the yellow thing or the fat kind of thing is coming on your way, move away from that field and don't go near that. That means you are near the bladder. Moving on to the posterior aspect, there are no adhesions on the posterior surface and you can see the lower limit of the cervix here. In cases of previous cesarean, there are usually only anterior adhesions. Now let's start the hysterectomy. The first step is clamping the cornual structures. First clamp we put is the straight clamp to prevent the backflow from the uterus. Now, as the patient is having a cyst in the right ovary, the plan of removal of this ovary has already been discussed with the patient. So what we are doing here, we are trying to decompress or aspirate the cyst. And what is the advantage of doing this? We get more space when we put a clamp on the infundibulopelvic ligament. We have already seen and understood that this is just a hemorrhagic cyst, so draining it is no problem. This is the infundibulopelvic ligament and the clamp here should be as close to ovary as possible. And in this clamp, we try to include even the round ligament. You might have to adjust your clamp a little bit to reach the correct point where both the clamps overlap each other. The medial aspect one for the backflow and the other one which is holding the infundibulopelvic ligament. The infundibulopelvic ligament you can see has been doubly clamped as it has important structures in it, and after clamping it is cut with the help of a cautery in an L-shaped fashion. If there are bleeders, usually they happen in the peritoneum because of the non-well-fitting clamp. It's better to coagulate them to control bleeding. After clamping and cutting, the third step is transfixation. So for transfixation, the first bite is taken at the tip of the clamp and the second at the junction of lower 2/3 and upper 1/3. The suture should go between the two metals, that is the clamp and the needle, to get a nice knot and nice fixation. Knots, I recommend all of you to practice very well because your hysterectomy is as good as your knots. So first knot should be a double throw. You should never lose the traction. Usually 3 knots are enough for any pedicle if you have put it correctly. If we are doing salpingectomy or salpingo-ovariotomy with hysterectomy, I prefer to remove this part once it is clamped, cut and ligated. Why? Because otherwise it keeps on hanging, keeps on disturbing and distracting throughout the remaining procedure. On the left side there were more adhesions, so we have to do a bit more of dissection to be able to clearly visualize and adequately clamp the cornual structures on the left side. So let's do it exactly the way we were doing it in the initial part, till we are able to see all the 3 cornual structures adequately. Similar to the right side, the first clamp will be just snugly put at the cornua to prevent the backflow. Now there are more adhesions which are going up to the tube and the ovarian ligament. So let's release those adhesions bit by bit. And then put the clamp. Now this side, because we are planning to retain this ovary, the clamp will be medial to the ovary, holding the fallopian tube, the ovarian ligament and the round ligament. For this pedicle, cautery can be used to cut as it is way too much outside the pelvis. Usually, to cut deeper structures, we do not use cautery. After cutting it, we have to transfix it, and the technique is exactly the same of transfixation. And as I have told you, you must learn and practice correct knots. We already have 2 videos which are dedicated on a model and a real patient, making you understand the exact technique how we transfix the pedicles. So if you want, you can go there and watch those videos. So after the cornual structures, tell me what's next. Yes, the next pedicle is the uterine artery. But before clamping and ligating the uterine artery, we must be sure that the bladder has been pushed down and retracted behind the retractor in totality. So we have to do a proper adhesiolysis now. While doing adhesiolysis, as I have told you before, beware of the yellow fat because it is the visceral fat which is wrapping around the bladder. So be very, very careful when you see this yellow fat. Now, can you see? We are in the process of approaching the correct plane, the wide cervical surface. But remember, bladder is very close, so be extremely careful as you go down. But finally, if you dissect properly, I'm sure all of you will get a proper plane. Now we have separated the bladder entirely from the cervical surface, and then we retract it with the retractor and then go ahead to do the uterine artery ligation. So uterine artery is done at the level of internal os of the cervix. Don't go down, follow the landmarks. As I told you, only for corneal structures I usually teach that you can use cautery. Lower down, either you can use the scissors or the knife. Cut it in a good L-shaped fashion to have a nice pedicle to tie. And then transfix it as mentioned earlier. Now it looks like the clamp is going to slip, and it has slipped. But even if your clamp slips, don't panic. Stay calm and do what you can do best. So we have cauterized the uterine artery here, and we are proceeding with transfixation. But in these kind of cases, don't shy away to put another clamp and to secure the uterine artery properly, because this is the most important vessel pedicle in hysterectomy. A better idea I can give you, which I teach to all my students also, when the patient is getting anesthetized and positioned, please go to the instrument tray and check all your clamps, whether they are closing properly or not. If you can just spend 5 minutes to do this procedure routinely, it will become your habit, and then you will not struggle while the surgery. Now move on to the other side. Clamp the uterine artery of the left side too, exactly at the level of internal os. For backflow, we have put another clamp, which is actually an artery forceps here. The uterus is small and the uterine artery is not that dilated. This is the advantage in this hysterectomy, which will not be there if the uterus is very much enlarged in size. So keep that in mind. Put a nice L-shaped incision before transfixation to have a nice pedicle. Then transfix. Throughout the hysterectomy, the suture material what we are using is Vicryl number 1. The loop should always come behind the back of the clamp, and the knot should also be tied behind the back of the clamp. I will tell you how to put the knot once. So wrap one end, the longer end, on one of the index fingers. Make a loop out of that and take the smaller end through that loop. Cross your hands to make a cross knot or a square knot, and then second knot with single throw, and also the third knot with a single throw. To go to the lower pedicles, that is uterosacral and angle of the vagina, let's dissect the bladder a bit more to get a clear surface so that we are 100% satisfied and safe. We must also check the posterior aspect. You can see the V-shaped attachment of the uterosacral ligaments here. Remember, any hysterectomy you might be doing, the next pedicle should always be medial to the earlier pedicle. So this is the clamp which is medially put to the uterine artery pedicle. You can see it is medial to the knot, and you have to clamp the uterosacral properly here. Once clamped, you can cut it with the help of a knife. to take a bit of cervical tissue in the clamp so that the fixation is better. Uterosacral ligaments will later be used to tie with the vault to prevent vault prolapse. Can you see again the nicely tied uterosacral ligament? When you do hysterectomy, each and every ligament you should identify and do it properly. Now we keep one end of this uterosacral ligament long for apical suspension. After this, come to the other side and do exactly the same. Clamp with a straight clamp, cut it with a knife, taking a bit of cervical tissue into it, and then transfix. Exactly the same way. First bite at the tip of the clamp, second bite at the junction of upper 1/3 and lower 2/3. Do you want to understand the knot again? Loop the longer end on the index finger and take the shorter end 2 times through this loop. Change your hands to get a squared knot, and then while the assistant is releasing the clamp, you tighten your knot, and then second knot and third knot. I'm just putting a fourth knot and a fifth knot to show you how it is done, but trust me, 3 knots are more than enough. After this, you must clearly delineate the lower margin of the cervix to be able to clamp the vaginal angles. One clamp on one vaginal angle and the other clamp simultaneously on the other vaginal angle. In one technique, in the simpler technique, you can overlap these 2 clamps and cut above the clamp bit by bit with the help of a nice scissors. Be careful, if the clamp slips, you need to hold it again. Remember that it has the descending branch of cervical artery, which is very important and can lead to hemorrhage in the post-operative period. Check this specimen to ensure that the entire cervix has been removed. After this, first take both the vaginal angles separately. Remember that it has a very important artery, and which artery is that? It is the descending cervical artery. So we transfix on both sides of the vagina, that is the vaginal angle with the artery in it. Take your time, but do it properly. Again, remember that the knot should be tight, and as we are going deeper in the pelvic cavity, you can use 2 fingers or a finger and a thumb to push your knot down and tighten it adequately. This vaginal angle also, after transfixing it, we will keep one end of the suture long and tie this long suture with the suture which we have left long from the uterosacral ligament of the ipsilateral side. And what it is going to do, it will help us to suspend the vault so that the chance, the risk of wall prolapse is reduced. So uterosacral is now attached to the vaginal vault, which will keep it lifted up and prevent the recurrence or prevent the occurrence of wall prolapse. Similarly, we go on to the other side, see how the peritoneum also is included posteriorly. Sometimes this peritoneum causes oozing of vault or bleeding here. So better to include it in your suture. The exact procedure is being repeated here on the left side too. So first we secure the vaginal angle and then keep one end of the suture long, which will be tied to the uterosacral ligament of the same side to prevent wall prolapse or the risk of wall prolapse later on. Now, if you feel the need, the center part can also be sutured. You may take a single vault suture or you may go continuously also. You can do whatever you feel like. Ultimately, the purpose is to close the vault. So here what we are doing, we have taken two angles, done the vault suspension, and the middle part which was remaining, we are taking a figure of 8 suture here. Figure of 8 suture helps for hemostasis as well as helps the closure of the vault, approximating the two vaginal walls in the middle part. From this beginners or learners video, if you want me to give one message, one take-home message, my message would be to learn proper knotting technique. Just learn one kind of knot and do it properly. Learn it before surgery so that you can do it efficiently during the surgery. So with this, your hysterectomy is complete. In a difficult patient with lot of adhesion, the vault is good, it is not bleeding, but the place where you have done adhesiolysis, a bit of bleeding is there. So secure those bleeding points. Usually these are just oozings after adhesiolysis and can be taken care of just with simple cautery at few points. For cautery, always lift the tissues up and then coagulate a bit. After this, count the mops and instruments and close the abdomen. That's it. I hope now you don't feel that previous 2 LSCs is a difficult hysterectomy, and the incision is also small and nice.